Welcome everyone. I would like to invite you to this Take 10 session. As you know, the 10 means 10 minutes. So my stress with you today is to discuss biologic dose and optimization combination in 10 minutes. I wish I had 10 hours. I asked if it could be 10 hours, but apparently we're stuck with 10 minutes. So it's a pleasure to be with you. I have also the honor to be one of the counselor of the IPC. I've been counselor now for I don't know how many years, but it's been extremely helpful for my patients, helpful for me, and I guess helpful also for you. So when I was invited to discuss in about 10 minutes this subject, I certainly was very pleased to accept. I have absolutely no disclosure for this presentation. And as I said, we have about 10 minutes, so we'll try to make it concise and short. Now, you probably have seen this treat to target paper that was prescribed by Professor Morietz in 2011. You have seen probably this chart probably 50 times. I think that this treat to target is not anymore true in 2021. But what is probably true is the modification strategies on the left, the box on the left lower side here. I'll just magnify this for you. So if we look at the modification strategies, these are still certainly in effect. You can increase the dose of a medication. You can reduce the dose intervals. You can add a topical. You can add another systemic, or you can just switch or change your medication altogether. So these are all strategies. Just to remind you the frequency of administration of biological agents. Actually, there's two drugs missing here. Tildrakizumab is not in this chart because when I prepared that slide, it was not yet approved in Canada, so it's not there. But tildrakizumab will be in the same frequency as ustekinumab and risankizumab. And the other, which is not one, the new anti-IL-17, bimekizumab. And this one is given every 4 weeks for the first 16 weeks and every 8 weeks thereafter. So this is just for your reference to, and you see the number of needles that are required for a different medication. And this actually may be useful in your practice. So when we think of dose optimization, certainly escalating the dose or increasing the dose frequency is probably what we're doing most of the time. As you know, these are usually not approved. It's off-label, so you have to keep this in mind. But they are certainly commonly used in clinical practice, certainly quite extensively in Canada. And I must say that we're quite lucky in Canada because actually we can optimize treatment fairly easy. And for the most part, they are approved by the insurance or by payers. And you have to keep in mind also that if you're planning to do this, you have to first look what if it is going to impact the insurance or copay for your patients, for example, because obviously you don't want to make a switch or dose optimize and then suddenly your patients have no more coverage. So you have to keep this in mind before you apply those strategies. So this is just to show you, for example, I highlighted the box on the top for example, for adalimumab. This is the standard dose that you know very well, 80 milligram followed by 40 milligram every other week. But in many cases, you have to do the 40 milligram once weekly. This is an example of dose optimization for adalimumab. And etanercept, as you know, is given 50 milligram twice weekly for the first 3 months. And then you're supposed to reduce to once weekly. But in many patients, actually, they have to keep the twice weekly on the long term. And you have also for the other medications, some example of dose optimization. Now, you remember that slide that I just showed you a few minutes ago for dose combination. So enhance efficacy, speed up the onset of action, potential for dose reduction, maybe reduce the risk of associated comorbidities, immunogenicity, and increase REM concentration. So what you can do to combine therapy, so combination, you can really do all kinds of things. You can use biological with topicals, for example, which is used quite extensively. And I included here intralesional injection, which is certainly extremely popular in my practice. I think that I do this almost 2 or 3 times every day when I see patients and follow up. They have a small plaque or 2 small plaques left. I will just inject them with triamcinolone alone, and this works very well, and quite often these plaques will not come back. You can use biologic with phototherapy, biologic with acitretin, biologic with methotrexate, biologic with apremilast, and maybe also combine 2 biologics together. I have no problem with the concept The problem is that this becomes, as you know, extremely expensive. So you have to make sure that somebody will cover for this. For the next 3 slides, I will show you the level of evidence. I will go very quickly, but just to show you that regardless of the combination that you are going to use, there is some evidence in the literature to support you. So the first one is about apremilast, cyclosporine, and methotrexate. So this is the level of evidence which is presently available if you combine biologic with apremilast, cyclosporine, and methotrexate. This is there for reference, and I will be more than pleased to share this with you if ever you need these references. The next slide is about phototherapy and biologic. Actually, there's a fair amount of literature of combining biologic with phototherapy, so it's there. So if you're using one of these strategies, there's something that will back you up. And the last one is biologics with topical agents. And once again, a lot of literature with this type of combination. So in summary, what we can say that if you combine a biologic with conventional systemic therapy, you might improve efficacy, you can optimize risk-benefit profile, and you can enhance also long-term management and probably adherence to treatment and long-term also retention rates, I think, which is very, very welcome. If you look at TNF and methotrexate, certainly it's safe. It might also help, as I said earlier, with comorbidities, normally cardiac comorbidities and so on. So we have to keep in mind also that combination is very nice, but there is limitation to combine. Safety, you're using 2 agents, so you have to look at the safety profile of one agent A and safety profile of agent B. Cost, especially, for example, if you combine a biologic with apremilast, you're looking at 2 expensive medications, so you have to keep this in mind. Will it be covered and so on? Convenience, a patient that was used to use a needle every 3 months might now have to use a needle and maybe a medication every day. So you have to buy them out every day or once a week if using methotrexate, for example. And then you will have to monitor the medication, the biologic, if you're doing monitoring with the biologic, and monitor the combination therapy that you are using. Now, this is all very good, but what about dose reduction, de-escalation, or intermittent therapy? Because, I mean, if you have a patient doing super well for 5 years, can you reduce? Can you stop temporarily and so on? So there was a nice paper that was just published last month by IPC counselors. So they did a real good work. So they did actually a survey among dermatologists of the IPC, and I'll show you how it worked. And the title was Attitude and Behaviors Regarding Dose Reduction of Biologics for Psoriasis. And this was a survey that was done on dermatologists working with the IPC. So in a nutshell, it was an e-survey of 27 questions. It was sent to the IPC counselors. There's 114 IPC counselors. 57 responded, but 4 were removed because they were not biologic prescribers, so we decided to remove those. So the analysis was done on 53 respondents, which is actually pretty good. And what it showed that actually 70% of the one that responded the survey applied dose reduction, and 30% did not apply dose reduction. So that was quite interesting. Now, for the dermatologists who were applying dose reduction, cost saving was by far the main reason, close to 90%. And if we look at the 16 that were not doing dose reduction, 94% actually did not do dose reduction because there was a lack of scientific evidence and guidelines and uncertainty about the maybe drug reduction effects and risk. So because of the lack of evidence, these dermatologists did not apply dose reduction. I must say that I answered the survey and I'm one of the non-drug reduction, but that's all right. That's something we can discuss later on for us. So as more effective a medication become available, will there still be a place for optimization and combination? I think that you agree that the newer agents are definitely super effective, but on the other end, regardless how your medication is effective, I think that those combination optimization will probably be sometimes required even with the more effective medication that are presently on the market. So in summary, optimization of current biologic therapy is important to achieve the greatest response. A variety of safe and effective biologic optimization strategies are available. There's certainly very good evidence to support the use of at least one optimization strategy before switching. So it seems that for the most part, you may first optimize, and if it does not work, maybe think about switching. This is something else we can discuss also together, because not everybody agree with this. Patient access also to a new biologic must be considered before doing the switch or the modification. And if optimization does not work, well, consider switching biologic. So this is what I had to say. I guess I went pretty close in 10 minutes. So I thank you very much for your attention, and please stay safe and enjoy life, and combination optimization consider in your practice. So thank you very, very much, and stay safe.